Hello? Cool. Good evening, everyone. Hi, and welcome. Welcome to all the guys that are online as well. We are pleased to have you at the event this evening. It was really short notice, so I'm very well pleased with the turnout. So thank you and all for being here. Without much ado, I just really want to reach out to Melanie Charles and Keith Ruthanam from the Department of Health, Deputy Directors of Mental Health and Substance Abuse Directorate. It's really an honor and a privilege to have you joining us this evening, Normally on a Wednesday evening, the group sort of like lines this whole auditorium, and we start with praise and worship ramped up real loud. But today's a little bit different. We've been a little bit more considerate of our mental health and the guys that are around us as well. We're really honored to have you both here this evening. More so that we are able to collaborate and partner with the Department of Health in bringing out systems and protocols and procedures of how we can further equip ourselves and support people suffering from mental health, how to identify those areas and how we can refer and be part of the solution. We know as Project Exodus that's a critical part of our job description, if I can put it that way. A critical part of our passion is how do we reach out for the one? How do we not get to the one? And we know in our country mental health is a dire need, that there are only 0.3% of the people who need help are getting access to help for their mental health. We know that substance abuse and mental health are really closely intertwined, and unless the one is treated, often the other goes unresolved. So without further ado, Keith, you're up. So big hand, please. Thank you.
Good evening, everyone. It's so lovely to see such a nice turnout today. We do know that there is no health without mental health. So I'm going to be doing the first part of the presentation. So I'm going to take you through the mental health literacy module. It's our first of a many series to come because unfortunately I could not cut down 3 hours of training for 1 hour now. So today's version is a shortened version. It's an overview of mental health and what we can do to try and improve our mental health. So we're going to start with a little exercise first. So you're all going to stand. We're going to release some stress to begin with. So we're going to practice some deep breathing exercises. We're going to relieve all the stress. I have an ulterior motive. It's just to make sure that you all pay attention when I actually do present, right? So on the count of 4, you're going to then breathe in. You're going to hold it for 4 seconds. We're going to go in a whole loop until we complete a square. You're going to take deep breaths, and then you're going to exhale on my count of 4. So when I say 1, 2, 3, 4, you're going to take a deep breath. 1, 2, 3, 4. You then exhale, releasing all the pressure that you should be having from all these tiring days that we are now experiencing. So let's go for it. So we're going to go 1, 2, 3, 4. Deep breath. 1, 2, 3, 4. Exhale. That's one line only. 1, 2, 3, 4. 1, 2, 3, 4. Breathe in again. 1, 2, 3, 4. Hold. Think you're in this beautiful island with your bikinis and your Speedos. Exhale. One more time. 1, 2, 3, 4. And 1, 2, 3, 4. Exhale. So now that all the stress is gone, we're going to do a little exercise to see whether our mind and our body is in tune with each another. So, I'm going to leave my mic down. I'm sure you'll be able to hear me. I love to scream and shout.
Yeah.
So, with your hands, you are going to illustrate the time of day that I'm going to tell you this. So, if it's 12 o'clock, 12 o'clock.
Yeah.
If it's 6 o'clock, 6 o'clock. If it's 6:15, you're going to figure it out. So, we're going to do a little exercise to see whether your mind and your body is in tune with each other.
Yeah.
So, let's start with an easy one. 6 o'clock. 12 o'clock. 9:15. 3:45. 10:05. All these minds are not working, you may sit down. So in order to improve mental health, it does not only rely on one person. It takes a whole system to make mental health work, whether it be government departments, schools, churches, provincial departments. Everyone needs to work together in order to improve mental health. So I have a little jug here, and I have different water with different sized tumblers that you could see here. Let us say that this is mental health within KZN. We've got a good start to mental health, but we want to improve it to such an extent that this glass is actually full. So let's say this is the National Department of Health. They contribute. Apologies if I missed the place, right? Let's say this is the provincial department. Let's say this is schools. And let's say this is you. I've heard about all the excellent work that you all have been doing in order to start the support groups within the eThekwini districts and across the province. So you are also playing a massive role in improving mental health within the province. So I think you deserve a big round of applause for that. Unfortunately, you would know that we would never ever reach the top because there's always room for improvement in whatever we actually do. So we always have to keep trying and keep persevering. We're going to watch 2 short videos now. So you're going to pay attention to the videos and let us see about mental health throughout the world and some of the challenges that we do face.
I think it was 11 when my parents divorced. I got so affected. The trauma just kept accumulating.
I ended up being diagnosed with moderate to severe depression. I went through a roller coaster of emotions, from fear and anger to having uncontrollable tears any time of the day or night.
I had sexual abuse in my family for a long time, and I didn't remember it. It was pushed away. I was in depression.
I saw a psychiatrist, and then they recommended me to a psychotherapist. Started having joy again in life, and so I connected with people who have been through stuff.
In March this year, I started work at a college in Yellowknife. It felt like my world was growing again.
I was trying to get a therapist. That was the turning point for me, to have a place that I can talk.
I have a community, I call it a support system. And so that is really how gradually I was able to pick myself up.
It's okay not to be okay.
It is okay not to be okay. The second video is going to show us a little bit about stigma that we do experience when it comes to mental health.
Hola, disculpa por no llegar anoche. Lo siento. He estado hace tiempo con ganas de decirte algo. Últimamente estoy lidiando con mis problemas de salud mental.
I think if there was no stigma around mental health, I'd be more open about what I'm going through on the inside. And I don't know, maybe I'd find that other people in my life are actually going through the same thing.
Há alguns anos, comecei a contar para outras pessoas sobre minha ansiedade. Isso me ajudou a descobrir ótimas formas de como lidar com ela.
Soy muy sociable. Creo que si hablara sobre mis problemas de la salud mental, simplemente no lo creerían. Por eso no hablo de ello.
Me preocupa que si la gente se enterara de mi salud mental, pensarán que soy débil. Por eso me aislé. Pero creo que voy a cambiar esto.
So hopefully by the end of today, all those ideas that we have and the stereotypes that we have about mental illness will go away, and that we can actually focus on promoting mental health. So I'm going to take you through my presentation now. We've talked a lot about COVID being the pandemic. However, there's a new pandemic that is developing, and Sybil says it quite well. Mental health is the new pandemic. Following COVID, we have seen massive increases in mental illnesses from anxiety, depression, and post-traumatic stress disorder. So we have to do our part in order to win this battle that we're facing with this particular pandemic. So COVID may be over, so they say, but the mental health pandemic remains. So according to the WHO, 1 in 8 people will live with a mental health condition. And 1 in 4 will develop that. And I'm sure as we've progressed through COVID, those numbers will have actually increased by now. This is the disease ranking of the burden of disease in South Africa. So you can see where mental illness actually falls. Neuropsychiatric conditions fall at number 3, just behind HIV and AIDS and other infectious diseases. So you can see the impact of the problem within South Africa. The burden of mental disease is increasing. There have been recent studies that have been completed. There was the Global Health Survey Monitor, which said that globally, majority of the people felt that mental health was the biggest health problem that they were facing in their respective countries. And from the World State of Mental Health report, you would have seen that South Africa ranked the lowest on the mental health well-being when they used the mental health quotient score of just 46. The mental health impact is quite vast. Yes, it affects the individual who is experiencing that mental illness, but then bear in mind the family. The family go through the processes of what that person is actually dealing with as well. So the impact of mental health is a ripple effect from the individual to the family, to the communities in where they live, nationally, internationally, personal, social, economic. The impacts are vast. We're seeing a massive increase in the days lost at work due to mental illness now. Previously, it may have been all other conditions, but now mental health is playing a big aspect in people actually staying away from work and having to receive treatment and care. Something that was very exciting this year was that the WHO had launched the World Mental Health Report. And you would have seen that the whole focus was on trying to transform the mental health system. I love this slide here because it shows some of the key shifts from the past to the present. So you'll see there's a whole new aspect that they are now advocating for. So we're going to look at the after part here, which says, mental health must be valued by all. Equal participation in society, free from discrimination. Services are appropriately budgeted and resources across all sectors. Real and active multi-sectoral collaboration on the determination of mental health. Strategic and well-functioning promotion and prevention programs. A balanced evidence-based biopsychosocial approach to care. Person-centered approach, a human rights-based recovery-orientated care, mental health care is embedded in services across all sectors, coordinated services with universal health coverage, a network of community-based mental health services, mental health care integrated into our primary healthcare system, and where you are going to be playing a very vital role, community providers and informal support are activated and strengthened to support people. But we're now going to try and also integrate and building mental health in our community. That again just illustrates, I love this community part because it's the part of why we're here today. This year, during October, we celebrate World Mental Health Month. So World Mental Health Day is celebrated on the 10th of October. This year's theme was absolutely significant. It was based on make mental health and well-being for all a global priority. Sometimes we neglect our vulnerable groups. This is the time that we include everybody. So here we go on what is mental health. So when we're talking mental health, we're talking what refers to cognitive, behavior, and emotional well-being. So basically, it's about the way we think, the way we feel, and the way we actually behave. So mental health is a state of well-being in which an individual can realize his own abilities. You're able to cope with your normal stresses of life. you are able to work productively, you're able to make contributions to society and the community. Mental health is not just the absence of mental illness. When we talk mental illness, we're talking about a variety of different conditions that will then affect the way we think, the way we feel, and the way we act. It can also affect our ability to go through our daily life. There are various causes for mental illnesses. So some may be biological factors due to our genes and brain chemistry, life experiences such as physical or psychological trauma and abuse, and we're seeing a lot of the cases here, especially the interrelationship between gender-based violence and the effects it's having on psychological health and well-being, family history of mental problems, environment, our daily stresses, work stresses. Melanie really stresses me out at work, so she's one of my causes of my stress that's there. Family stresses, financial stresses. It was quite interesting. I was reading an article which also showed a link between global warming and mental health to such an extent that now when we're talking about global warming and impacts, we must also include mental health in that particular strategy. And it's actually quite true. You would have seen the changes happening in our weather patterns, the horrific floods that happened in Pakistan recently, and the devastation that it caused. Yes, they lost their homes. Yes, they may have lost loved ones. But imagine the impact psychologically it has had on them, the anxiety, the depression. Our habits, and one of the reasons why Melanie and I always fight when it comes to hospitals, we're seeing the abuse of substances being one of the causes of our mental health issues as well, and our busy lifestyles. So those are some of the contributing factors or causes for mental illness. So when we look at what could be the early warning signs when it comes to mental illness, too much of a good thing is a bad thing. Too much of a bad thing is almost a bad thing. So some of the signs and symptoms that we should be wary about is eating or sleeping too much or too little, pulling away from our usual activities that we used to enjoy, staying away from the people that we used to like spending time with, having low or no energy, feeling numb or like nothing else matters, having unexplained aches and pains, feeling helpless and hopeless, drinking, smoking, using drugs more than usual, feeling unusually confused, forgetful, on the edge, angry, upset, worried, and scared, to such an extent that it starts affecting our daily functioning and our relationships with people, yelling and fighting with our family and friends, experiencing severe mood swings that then affects or causes problems within our relationships, having persistent thoughts and memories you just can't get out of your head, hearing voices or believing things that are not true, feeling that things are happening to you that is not actually happening, having delusions, thinking of harming yourself, inability to perform daily tasks, and taking care of your kids and your family. So these are some of the basic warning signs that we should be aware of. Remember, once it starts affecting your daily functioning and your relationship, it is a point for concern. There are many common mental illnesses that we are now focused on. You would have found there was a lot of talk on things such as schizophrenia, bipolar, but some of the mental health conditions that we were not detecting and not picking up that was causing a deterioration in people were the common mental disorders that are quite more frequent. So common mental disorders include anxiety, depression, substance abuse. We're seeing more common eating disorders, personality disorders as well. So some of the common mental illnesses, we're seeing major depressive disorder, where we see causes feelings of extreme sadness or hopelessness, and that lasts for approximately about 2 weeks. It affects people's appetite, their sleep, their energy, their memory. People become so upset about their lives that they also may think or try to commit suicide. General anxiety disorder goes beyond our regular everyday anxiety or stress. It causes a person to become extremely worried about many things, even when there's no or little reason for it. Sometimes worry can keep people with general with our general anxiety disorder from accomplishing their daily tasks and their chores. Post-traumatic stress disorder, which is a mental illness that is triggered by an experience or witnessing a traumatic event. Sometimes it may include flashbacks, reliving that event, avoiding any memories, and being easily startled or on the edge. We see this very common with people that have been involved in accidents. We see it with our policemen, our emergency personnel that have to deal with accident scenes, etc., our army personnel. Post-traumatic stress disorder has been quite frequent. Can you imagine the people in the Ukraine, what they may be going through after the war and the devastation that is taking place there? Substance abuse and addiction, which Melanie is going to go through quite in-depthly. Social anxiety disorder, sometimes called social phobia, causes an extreme fear of social situations. People with social anxiety may be very nervous about being around other people. They may feel like they're being judged. I have a partner back at home who is extremely afraid of heights. So one day we were going up this Drakensberg thing to such an extent that as soon as it started going higher and higher, he became so anxious, he became so agitated, the physical symptoms started taking place to such an extent he had to go in the middle of the booth and sit down so that he actually couldn't see what was actually happening. So a fear of heights that's there. I know they're going to kill me when I go back home. Obsessive compulsive disorder causes constant and repetitive thoughts or obsessions. These thoughts happen with unnecessary and unreasonable desires to carry out such behavior or compulsions. Many people with OCD realize that their thoughts and actions are unreasonable, but they cannot stop it. I wonder about Melanie in that one and her cleaning habits. Eating disorders are also some of the common mental illnesses that we've seen. Causes people to have constant fear and anxiety around food. They may have altered body image, purge, vomit, exercise intensely, and to avoid getting fat. On the other extreme, they may eat excessively as a coping mechanism for emotional stress. So it's both ways, trying to lose weight or comfort eating. And you'll be surprised, we are seeing more and more males that are now suffering from the eating disorders, not just the females. So within the KZN Department of Health, what we have done, because we've noticed that anxiety, depression, and substance abuse is the three common mental disorders that is affecting society as a whole, we have developed what we call a brief mental health screening tool. It's a tool to help us to tell whether somebody is actually maybe having anxiety, depression, or substance abuse. So you can see we try to cut it down. It's both in English and isiZulu. It's on 7 key points that are there. And from that, we can determine whether someone may test positive or screen positive for depression, anxiety, and substance abuse. It's something that we'll be taking on in our next series as well, where we'll go in-depthly in some of the screening tools. So we have also developed various posters and pamphlets to help promote and understand mental illness, which we'll also be sharing with you. So this one is on anxiety. You can see that we've broken it down to how one thinks, how one feels, how one acts, what you could do at home, and then hotlines that you could call, a video that you can watch and scan. So let's take an example of this one. When we look at anxiety, when you think, people worry about the same thing over and over again. They doubt themselves a lot. They have poor concentration. They feel overwhelmed. They feel nervous. They feel fearful about many things. Physically, they may experience muscle tension, indigestion, runny tummy, experiencing palpitation. Then they act. They do things over and over, even when there's no need. They panic. They become irritable and restless. Things that you can do by yourself, making contact with someone, making contact with a friend, doing something that you enjoy, practice deep breathing exercises. If that does not work, there are hotlines such as SADAC, which you can call. If that does not work, we offer various services at our clinic and our hospitals, and you can access those services. So we've done the same with depression. So you can see it's the same model that we applied, the think, the feel, the act, things that you can do. You can see for depression, do something that you enjoy. Try exercising. Try talking to a friend. During COVID, we had a lot of people that were suffering with loss and grief. So we also developed a little sort of a pamphlet for them to deal with loss and grief. Remember when COVID was at its highest, we could not attend any funerals, we couldn't be part of saying goodbye, and people really suffered with that. They were unable to deal with the loss and grief, they were unable to come to terms with their death. So we looked at different methods that we could teach people to overcome that. For example, allowing selected visitors for observing social distancing, when observing social distancing, seeking spiritual advice, connecting via WhatsApp and other social platforms. So with the tools comes a whole training manual, which we're going to share with you all in session number 2. So we teach you how to read the manual, how to go through the poster, how to give health education to the support groups that you are going to be running, correct? I don't hear a yes there. Aha. In conjunction with the University of KwaZulu-Natal Rural Health, we've also developed what we call a community mental health education and detection tool. So you'll find this is the whole tool that we developed. It takes a storytelling approach. So when you interact with people, when we visit households, we're able to tell a story. People are able to connect with that story and then see whether you're actually suffering from some sort of our mental health conditions. So it's an excellent process, which we'll also take forward with you, of telling these stories and trying to get help within the households. So it's a way of educating a household, educating your support groups, as well as detecting and then referring people to the relevant care. I thought I'd include this in today's presentation because it was quite sad recently to hear that a lady was suffering from dementia. The community could not understand that she actually had dementia. To such an extent, there was this whole belief that she was bewitched and that she had demons in her, etc. And they did not actually understand the particular condition of her. I think there was even instances where there was some sort of abuse towards her because no one actually understood what dementia was. It's quite common amongst our elderly, not limited to the elderly, but more common amongst our elderly. So it is a syndrome due to the illness of the brain. It is more common in older people, but it can occur at old age, at any age, sorry. It usually gets progressive or worse. People have the following signs and symptoms: feeling depressed, changes in personality, memory loss, confusion, wandering, loss of emotions or control, changes in social behavior, agitation, hallucinations, and delusions. And if dementia is not controlled, you'll find that it can cause not being able to care for oneself, sleep difficulties, the person may become unsafe or even have self-harm. So I had circumstances where someone who was suffering from dementia ended up just going to a neighbor's house, taking all her belongings, because she thought that was her house. She forgot where she had lived. She would park her car in all different areas and not know where it was. She would go visiting the beach thinking that she can swim when she could not swim. So really, it became an issue of protecting her and making sure that she does not harm herself. So it can get worse. What makes it better or decreases complication is that we understand what to do. So carers with dementia, we need to give them support and planning. We need to offer care and hospitalization where necessary, provide regular orientation to time, to names, to people, etc. So this was just some of the ways that we can care for people with dementia. We must always maintain the dignity of the particular person. What people do and say can be quite disturbing. You can imagine how that lady would have felt when people thought and kept saying that she was bewitched or demons were following her. Avoid discussing the person's condition in their presence. Telling a person with dementia the diagnosis requires sensitivity and skill. We must establish routines with them. So routine decreases the decisions that need to be made. It provides security for demented persons. It helps promote the person into remembering what they were meant to do, brings order and structure to their daily life. Communication is important. When language becomes impaired, the person needs to rely on other senses such as touch and such as sight. Make sure eyesight and hearing is not impaired. If they have a hearing aid, make sure that it is functioning correctly. Speak clearly, speak slowly, speak face to face and at eye level. Do not shout at them. Pay attention to their body language and to your own body language. Be aware of your own body language. Make sure that you have their attention before you are actually speaking. Using of memory aids becomes important. Keeping familiar objects around, making sure that the watch and clock shows the correct time, putting up calendars, putting up a message board, putting up photos so that they're able to remember and recognize close families and friends. We do have less common and more severe mental illnesses, such as bipolar disorder. It's a chronic mental illness that affects 2 to 3% of our population. It is characterized by episodes of energetic manic highs or extreme depressive lows. These can affect a person's energy, their ability to think reasonably. Mood swings caused by bipolar disorders are much more severe than the small ups and downs that most of us may experience. Schizophrenia impairs a person's perception of reality and the world around them. It interferes with their connection with people, often characterized with people that are having hallucinations, delusions, they're hearing voices. These can potentially put them in a dangerous situation if left untreated, but it affects a small percentage of the population. I love this picture again because Melanie will kill me when I say that your color coordination sometimes makes me wonder. But it just depicts the manic phase and the depressive phase. So you can see the manic phase being all elevated and the depressive phase actually being on the lower part. How do we diagnose a mental illness? So diagnosing a mental disorder is a multi-stepped approach. First, you'll find that the doctors will try to exclude any physical issues that could be contributing to your symptoms. A physical exam is often done. A lab test or blood tests are also taken. We also take what we say a full mental health history. Sometimes we speak to the family, the friends to get us collateral. Some people may need to be referred to a mental health expert. Because mental health can be complex, symptoms differ from person to person, and people are individuals by nature. It may take a few appointments before you actually get a full diagnosis. There are no blood tests or brain scans which will definitely tell you what your diagnosis is. Can mental illness be treated? Treatment is not one size fits all. Often mental illness is chronic and there is no cure, but treatment aims to reduce the symptoms, address the underlying causes, maximize function. With treatment, the majority of people should go back to functioning normally. We use what we call a biopsychosocial approach. So it's not only medication. We teach and educate on lifestyle changes, eating healthy, exercising, a balanced lifestyle, substance rehabilitation for those that suffer from substance abuse, medication, psychotherapy, social worker or occupational intervention, access to support groups, or you can be treated as an outpatient. And if your condition is severe, there's also the other option of where you can be admitted to hospital, either as a voluntary patient, assisted patient, or even an involuntary patient where you may be a danger to yourself or to others. Recovery. Recovery from mental health disorders requires an ongoing process. You need to adhere to the treatment protocols that have been given to you, healthy lifestyle changes. In some instances, medication may be on an ongoing basis. For others, you may be able to stop it. But what recovery means for you may be different to what recovery means to another person. So a question, why do people not like to take their psychiatric medication? I got some nice giveaways if you can answer. What are some of the reasons why people decide to default on their psychiatric medication? Aha, let's see how good you are. Right, go for it. Afraid for becoming dependent is one. What else? Yeah. Such as? What else? Aha, yes. This side is quite, very quiet, yes. The one at the back? They don't like being numb. What else? Yeah, so those are some of the common reasons why people actually default on the psychiatric medication. Plus, also remember that the stigma also affects. Nobody wants to be known for taking psychiatric medication. Some of the medication actually, it may make you drowsy, they can't go back to work, it may affect sexual functioning. Most men don't like to take the psychiatric medication because it may cause sexual dysfunction. Some of the psychiatric medication causes people to gain weight, and which they don't like. But most often people think that they're getting better, and then they automatically just stop the medication and they don't continue with it. There are various ways that we can stay mentally healthy. So there's lots of things. Keeping a positive attitude is number one. Always looking at the brighter side of things. Staying physically active, which Melanie does not do. She has a gym membership, which she does not go to. Helping other people and knowing when to say no. Melanie is always my pawn when I teach, so she always gets the bad end of it. Getting enough sleep, eating a healthy diet, spending time on self-care, getting professional help if you need it, socializing with people who you enjoy spending time with, focusing and using effective coping skills, staying away from alcohol and drugs, and talking about mental illness to beat the stigma. Meditation is also great, so learning meditation and how to do the meditation is also one of the best ways to relieve stress. These are some of the benefits of meditation. It increases the energy level, creativity, and spontaneity, lowers the blood pressure, increases exercise tolerance, better concentration, decreases our stress, depression, and anxiety, fewer cravings for alcohol and cigarettes, increased job satisfaction, and better relationship with others. So I think we should have a whole session on meditation. Don't you agree? To come. Other strategies. Things that you can control. Things that you can't, don't let it bother you down. So you can't control your attitude. You can't control turning off the news. You can't control finding fun things to do at home. You can't control limiting your social media. Things that you can't control is what other people may think, the actions of others, predicting what will happen. Sometimes focusing on those elements is what heightens our stress and can really lead to anxiety and depression. So things that you can't control, they're out of your control. Control the things that you can, and always enjoy a nice cup of chamomile tea. Mm-hmm. Mindfulness is also another good tool to use when we're talking about mental health strategies. So upon waking up, bring attention to your breathing. We taught good deep breathing exercises today. Focus on your breathing and experience the effects of breathing throughout your body. Don't rush. Slow down. Enjoy something special in the morning, a blooming flower, the sounds of the birds, the wind in the trees. As you travel to work, don't shout at the taxi driver. Pay attention to how you walk or how you drive and ride the taxi or the bus. Take some deep breaths, relaxing throughout your body. When you stop at a traffic light or at the robot, pay attention to your breathing. Enjoy the landscape around you. We have a beautiful city here. There's such beautiful things around you. When you arrive at your destination, take a few minutes to orientate yourself. Again, breathing is very important. Calm yourself, relax your body, and then tackle your workday. At your desk, become aware of subtle signs of physical tension. Take a break, stretch around, walk, make fun at somebody, laugh. Laughing is good, huh? Use the repetitive events of the day or cues for many relaxation, like a knock on the door, walking down the hall. Walk mindfully to your car or to your taxi. Try to see and appreciate the environment around you. Try to take time for yourself. After getting home, try to take a few minutes for yourself alone to ease the transition to being at home again. As you sleep, let go of today and tomorrow. Take some slow, meaningful breaths and make sure that you have your adequate sleep. There is help out there. You can attend our local clinics, our local hospitals. At our local clinics, you will find that you will be screened for mental health. We have a whole process when you go through to our consultation room. There is a whole process of assessing and diagnosing and educating. If you need further help and care, we do have our hospitals who offer mental health care admissions, support, and outpatient services. There are emergency lines that you can connect with. There's Dr. Reddy that's there, SBIRT there, Suicide Crisis Line, Healthcare Workers Network, and also the South African Depression and Anxiety Group will offer a lot of support. So make use and educate people to make use of these services that are there. Now we're going to do a little experiment. So if you have your phone, you're going to take your phone to write. If you have a pen, you're also going to write. So if your answer is yes, you're going to score yourself 1. If your answer is no, you're going to score yourself 0. Easy, right? So we're going to go through the 10 questions. You're going to score 1 for yes, 0 for no. And don't lie, we'll catch you out. Number 1. So you ready? All of you got your pen or your phone? Here we go. There's no real difference between the term mentally ill and a mental illness. 2, people with mental illness tend to be dangerous and unpredictable. Yes or no? Right. 3, I worry about my son or daughter marrying someone with a mental illness. 4, I've made fun of people with mental illness in the past. 5, I don't know I could trust a co-worker who has a mental illness. 6, I'm scared of or stay away from people who appear to have a mental illness. 7, people with a mental illness are lazy or weak and just need to get over it. 8, once someone has a mental illness, they will never recover. 9, I would hesitate to hire someone with a history of mental illness. 10, I've used terms like crazy, psycho, nut job, retarded in reference to someone with a mental illness. Done? Scored yourself? The scoring is quite simple. 1 point for every yes response. Unless you scored 0, you have had thoughts, feelings, or behaviors which can contribute to increased stigma towards people with mental illness. The higher your score, the more likely it is that you have had these types of experience. If you had scored 0, congratulate yourself. Anyone that scored 0? Are you sure? Are you positive? Never a bad thought whatsoever? Okay, we'll give you a prize. I'm afraid to throw it in case it hits somebody on the head. Anyone who scored 1? Who scored a 0? Melanie, we'll dish it out here. So those that scored 1, I don't believe any of you, but you'll all get a prize at the end. But now that you have done the self-check and perhaps come to agree that there is room for improvement in all of us, correct? We really need to talk about advocating for us to reduce stigma at our homes, in our communities, in our churches, in the workplace. In fact, you'd find that often, even us as healthcare workers, we also contribute to stigma at times, and you don't even realize that you're actually doing so. So, don't label people who have a mental illness. Be conscious of the language that you use. Don't say, he is bipolar or she is schizophrenic. People are people, not their diagnoses. Don't be afraid of people who have mental illness. Yes, they may sometimes display unusual behaviors when their illness is more severe, but people with mental illness are more likely to be aren't more likely to be violent than the general population. In fact, we find that they become the victims of violence. So don't fall prey to inaccurate stereotypes from movies, such as that of a disturbed killer or weird co-worker. Don't be insensitive or blame people with their mental illness. It would be silly to tell someone just to buckle down and get over cancer or get over your diabetes. The same applies to mental illness. Also, don't assume that someone is okay just because they look, act okay, or sometimes smile and laugh. You never know what is behind someone. Depression and anxiety and other mental illnesses can often be hidden, but the person can still be in considerable internal distress. Provide support and reassurance when you know someone is having difficulty managing their illness. We all need to make differences. We all need to make a system change. We need to enhance mental health systems and care. We need to integrate mental health into all spheres. We need to make it a priority within the health systems. We need to follow a rights-based approach. Who knows what CRPD? CRPD? Close. He's got the rights part there. He was close. But we all need to read it. It's the Convention of Rights for People with Disability. It is actually something we all need to read because the human rights of everyone is very important, but the human rights with people with disability is also important and something that we often neglect. We need to establish mental health advocacy movements, and I'm hoping this will be the actual stepping stone in order to develop this within this province and maybe in other places where the groups are actually running. We have a lack of advocacy groups throughout the province, and it's something that we actually want to start to promote mental health. So be a role model or an advocate, talk openly about mental health, educate yourself and others, conduct awareness campaigns, encourage equality between physical and mental health, show compassion, advocate empowerment over shame, don't harbor the self-stigma, let the media know when they are being stigmatized, and speak out. Before I actually conclude, I found a very nice poem that was written in the post by Nishka Ramdiyal, and I'd like to read it for you. So it says, in all fairness, I would like to create an awareness about an issue in our society affecting minds of variety. Some call it a disorder, some call it insanity. Chosen words from those who love to increase their vanity. Day-to-day dealings like a ticking time bomb. When does the mind trigger let loose, sending us into a hailing storm? Depression, anxiety, confusion, and pain, haunting us like a monsoon, never-ending rain. Overwhelmed, unhappy, nervous, and insecure, with nowhere to run and hide, our minds cannot endure. Session after session, waiting for progression, waiting for succession, to avoiding all aggression. Why me, we ask, how do I go about completing the task? Mental health can be calming, like a yacht about to set sail. Oceans are flowing, winds blowing through your hair. Freedom of thought to your most favorite resort, without an inkling of ever being distraught. Agoraphobia, claustrophobia, phobias galore. Afraid of open spaces, so many phobias for sure. Teeth grinding, jaw locking, seconds of doom. Oh no, I think I'm going to die. Our fear starts to loom. Our hearts begin to race and the trembles start to shake. Lightheaded and dizzy, is this an earthquake? Bullets of sweat shooting at 100 kilometers per hour, struggling to breathe. Dear Lord, give me power. Our bellies start to quiver, a gastrointestinal rush. Bodies heating up, yet our skin is cold to the touch. All these components of mental health just wearing us thin, just because of the lack of serotonin. Oh wait, the catastrophe scale, said the shrink. Should I even be worried about the situation at hand? We were taught to control ourselves in times like these. Name 5 colors, 5 things, deep breaths, so that the lungs can expand. That is the truth about the feelings that we possess, the feeling that stopped us in our tracks under chaotic distress. Low self-esteem, a hopeless dream. Confidence at nil with no cup of happiness to fill. We cannot be strong in our souls, but weak upstairs. All we need is a listening ear and someone who cares. Breathe in, breathe out, practice as they say. Chanting, yoga, meditation should help day by day. As a fellow individual who has undergone the spoken words, these are certain aspects that have yet been awoken. There is light, a helping hand, and a positive sphere, family, companions, and help that is near. Never be afraid to come out and speak, whether it's Mental Health Month, year, or week. Lovely here. Thank you all for paying such good attention. We come to the end of our phase 1. Remember, this is part of a session. So next time that I come back, we'll be doing specific conditions and going in depth with it. And we're going through some of the various tools that can be used. So thank you so much. And I hope you enjoy session number 2 that is about to follow.
Brilliant. Great. Great. Thank you so much. Melanie, if I can follow up with some of the comments that Keith has made, so I shan't. But I do want to say that I've known Melanie for 16, 17 years. And Melanie's passion for what she does and fighting for human rights, for advocacy, for healing from substance abuse, from protocols and procedures has really stood out for a long time in KZN. And your reputation precedes you. It was 4 years ago that as we started launching Project Exodus that you stood on this platform as well in our very first conference and spoke openly about substance abuse and healing and recovery. So we're really honored to welcome you back. Great. Thank you. Guys, do you need a break? Any comfort break required? No, we're hungry.
Oh. Good stuff. Good evening. It's wonderful to see those eager faces out in the audience, and it's wonderful to be back here after a few years. And it's always wonderful to watch Conrad come up with new innovations. Like he says, I think we go back more than that. We go back, about 15, 16 years. And there's been so much of positive outcomes in the work that he has been doing. And I hope that this new initiative in setting up more community-based services is going to reach more people. Because what we really want to see is people out there in their homes, in their own communities, being able to access care, treatment, and rehabilitation closest to where they live. And we all know that we have a shortage of treatment services in the country, in the province, and we really want to make services more accessible. So today is going to be a difficult one because the training that I'm about to give you an overview of, or a bit of a snack on, is usually between 3 to 5 days long, and it's going to be a tough ask to cover it in 1 hour. But we're going to do our best, and like we said, this is going to be a series of sessions with you, and we hope that we can develop a relationship with you as we go along, and that your faces will become familiar to us and ours to you, and that we will be able to have more contact with you, and we can be a direct support to you as well. So I'm going to try and get to this slideshow. Great. So right at the outset, I must say that this training that I'm about to present to you is being done in partnership with ITTC. It's the International Technology Transfer Center, and it's actually a program that is being funded by the International Consortium of Universities in the US. It's part of the Columbia Plan. We have been very fortunate to have a relationship with Professor Goodman, who's based at UCT. And we've had a relationship with this organization from around 2018, and we've been rolling out SBIRT to our healthcare workers within our health facilities. So today, what we are going to focus on is the screening, the S part of SBIRT. It's quite intensive. There's a lot of terminology that you could be familiar with, but there's also terminology that may be kind of not the terms that you would commonly use, but it is clinical terminology, and I think it's important for all of us to be on the same page and even to be able to understand what clinicians say and speak about, and that we are able to relate to those terms as well. So our aim for today, hopefully, is the what, why, and the how. So we want to equip you with some knowledge, to give you a bit of insight in terms of what SBIRT is, and that we are using it as a public health model. Our attitudes towards screening, brief interventions, and referral to treatment. Many of you have had engagements with substance users and their families, and you may not see the need for it, so I'm here to change your attitude. I'm here to encourage you and motivate you to have an openness, an open mind and willingness about how we can improve the quality of care and how we can actually encourage people in the community to start speaking about their addictions, to start speaking about their abuse of a substance, and for them to be able to come to you and to be able to get some kind of assessment. And it's important for us to be able to do this in a non-judgmental, non-prejudicial, and also a very open-minded way. So the reason why we would want to implement such a screening within your setting is to also identify people with risk for substance use disorders. And for today, we're going to be talking a lot about alcohol use disorder. Okay, and the tool that we're going to be focusing on is audit. And you will be able to develop some skills on how to administer audit, the clinical tool. So you should know a lot about this. You are the fundis, substance abuse fundis. But the reason why we are so concerned as a Department of Health is because we in South Africa, right, have a huge problem with alcohol. Alcohol still remains the #1 drug of choice here in South Africa. It is legal. It is very accessible. We have a wide variety. Alcohol ranges in price, and it meets all categories, all economic classes. And as you can see, we we have a 30% heavy episodic drinking average as compared to the world weekly heavy episodic drinking average of 11.5%, right? That's more than double. We also have a huge problem with learners at school level having heavy binge drinking. And some of our studies have shown that grade 8s to 11 say they binge drink. That's 33% of school-going learners. And the accessibility of alcohol plays a huge role in this. And we all know about the prevalence of the taverns. And these taverns are even found near schools. So these are huge problems. And because you are in the community, and if you are aware of taverns close to schools, it becomes your role to be an advocate in that community, to call them out, to identify unlicensed taverns, and to be able to say, our children deserve to be taught in environments that are free of alcohol and surrounded by taverns. So keep your ears to the ground, keep your eyes peeled, and watch out for these taverns. We also have a higher rate of harm in South Africa as compared to other global regions. Again, South Africa, 38.7%, alcohol use, 30% tobacco, 8.4% cannabis, 2% other drugs, and 19.3% psychoactive drugs. And this has been taken from the SASH study, which is actually quite an old study. And remember, cannabis has also been legalized in the meantime. And we know that the consumption of cannabis is also very high, and that percentage could have gone up significantly. We have gender-based violence in our country, a huge problem. Together with the COVID pandemic came gender-based violence. And it was linked to the use of alcohol. And if you remember, during COVID, we had a ban on the sale of alcohol. And that in itself showed us how much alcohol has impacted on our societies and the burden on our healthcare systems. Just through banning alcohol sales, we were able to see a significant drop in the number of emergencies at our A&Es. So we also have a problem with alcohol and suicide, in which people are involved in positive alcohol blood levels. So a number of mortuary studies, for instance, will show that people who have committed suicide at high blood alcohol levels, and men predominantly will commit suicide whilst having high ingestion of alcohol. 56% of our road accident deaths are linked to alcohol, and we also have 32% of infectious diseases like HIV, TB linked to alcohol use. We have a serious problem in this country. Like Keith was saying, we have HIV, we have the HIV pandemic, we had our COVID pandemic, we have our mental health pandemic, and on top of all of this, we have an issue with alcohol. And we know that the alcohol impacts on decision making. So people who are living with HIV, they have riskier sexual behaviors, there's unprotected sex, and this also drives our HIV numbers, poor adherence, and decreased access to healthcare, accelerated disease progression through increased viral replication. So it's very important, if you in contact with anybody that is known to you who is HIV positive, it's important that you treat both the HIV as well as the addiction, because you cannot expect a person who is addicted to substances to be adherent to their chronic medication. So what we are having is a triple diagnosis. We have substance use disorders, we have TB, we have psychiatric disorders, and we have people living with AIDS. So can you imagine a person who is living with AIDS, has TB, then develops a psychiatric illness, and to cope with all of this, they start using substances, right? We are dealing with a compounded problem, and very, very difficult to manage, as you can imagine. So what is SBIRT? SBIRT is screening, brief interventions, and referral to treatment. For purposes of today, we are going to focus on the screening part. And screening means that we want to quickly assess the risk for a substance use and identify appropriate level of treatment. And SBIRT uses two clinical tools. This is AUDIT and DUDIT. AUDIT is used to screen for alcohol, and DUDIT is used to treat for test for other psychoactive drugs. In the next session, we will focus on the brief interventions. It focuses on increasing insight and awareness regarding the substance use and motivation towards behavior change. So whenever we do a screening, we can't just screen a person and leave it there and tell them, oh, well, you are high risk for alcohol use disorder, right? We have to perform a brief intervention. And that brief intervention usually requires a skill of motivational interviewing. It also requires you to assess where on the behavioral change phase is that person so that we can work with them towards behavior change. So all of this comes into the brief intervention, and we will go deeper into how to perform a brief intervention in our next session. And the referral to treatment is also very important. So at a community level, we may have the capacity to screen somebody. We may have the capacity to perform a brief intervention, to make some behavioral changes, and also to motivate them. But we may not have the ability to actually treat them. So it's important that we also manage how we refer people and who we refer them to as well, so that they will be able to access the necessary special care that they need. Right? So basically, it says in a nutshell, the primary goal of SBIRT model is to provide universal screening to identify individuals' risk of alcohol or other drug use disorders, and administer appropriate reinforcement, brief intervention, and/or referral to treatment. So the public health approach has always been a reactive one, right? So what happens is that we didn't really focus on proactive measures. We waited for people to come into our emergency rooms, having a seizure, having a psychotic episode, or being stabbed, or being in a road accident, or being abused through some violence related to alcohol or drugs. And so we have now taken a shift in the way we approach this. We want to have a more proactive approach. And we're hoping that you can also have that kind of approach. Because currently what you are dealing with or you're seeing is the after effects of the alcohol or drug abuse. You are supporting people who have already been through a journey of addiction, and now you're there with them trying to pick up the pieces of their lives and trying to put it together. But what if we changed the way we looked at addiction, and we changed our views and looked at not just the addict, but their family members as well? What if we looked at their children and be proactive about screening not just the person who is using, but also screening family members, screening their children, going to schools and doing some screening. And in your churches, if you could start screening in your churches as well, so that we can be able to identify early. Remember, addiction sometimes, especially with alcohol, takes a long period. Sometimes it could take 10 years, sometimes it could take 15 years before that person actually becomes addicted. So we have a window of opportunity when we see people using alcohol in a hazardous, in a harmful way, for us to intervene and to prevent the progression of that disease. So this is what we're attempting to do. And the best practice that we want to implement in our healthcare system is routine screening. And Keith mentioned that we've introduced a brief mental health screening tool with screens for depression, anxiety, and substance use disorder. Now, the questions that are asked in that brief screening tool, there are 3 questions, and it is linked to the audit. It's the short version of this audit, and it's called the Audit C. It's integrated into that screening tool, and every person that enters a clinic and goes into a consulting room will be screened with the use of the brief mental health screening tool. It would be wonderful if we could implement a screening tool even at a community level, so that we will be able to identify people early and we can intervene early on as well. So it's very simple, right? When we start screening, what we want to do is we want to immediately rule out non-problem users, right? A simple question about your use of alcohol or your use of drugs, and if they answer no, it means that we don't have to go further with the screening. The level of risk identified and the appropriate response intervention will be identified after you have conducted the screening. So the screening tool actually tells you, okay, this person has this level of problems, and this is the intervention that I need to implement. Okay, so we're going to go and see how this can be done. Okay, so there's the levels. When we screen, we identify the levels of risk. So naturally, when we talk about alcohol and drug use, it's on a continuum from no use, right, to moderate use or hazardous use, harmful, risky use, dependency, and addiction, right? Not every person that uses a substance is addicted, right? I'm sure you all know this, right? So once we start asking questions, we are able to determine at what level of risk is that person at. So no risk or haven't used, the intervention will be positive reinforcement. Yay, right? I've never used a substance in my life, right? Well done. Keep going. That's important, you know, and maybe a little bit of information thrown in there. If you haven't started, don't start, because if you do start, then this can only progress. It can only get worse, right? So encourage people not to start if they haven't started. If they are social drinkers, they moderate risk. Some of them may drink socially, but they may also drink over the standard drinking limits when they drink socially. So you're going to offer them some brief advice. If you drink socially, these are the standard drinking limits that you should be using. Then you have the moderate to high risk. These are harmful users, and more often than not, they have had maybe a binge drink, or they've used in an irresponsible way, and then we need to perform a brief intervention for these individuals. And severe risk, possible dependency, there's signs that they are drinking weekly, daily, there's signs of dependence. These ones we would be referring for specialized treatment. Okay. So, in summary, there's a need for an integrated approach. It's imperative for optimal client outcomes. We need to introduce the SBIRT model as a way to address these service needs, and we need to identify the participants' role in being able to screen for substance use and refer appropriately. So, in preparation for audit, I need to understand what you know about substance abusers. Tell me what you know. Tell me your experiences. I just want to hear from you. What do you know about them? Before, yes. Okay. Yeah. A vicious, ugly cycle. Yeah. What else? What has been your interaction? Your experiences, your interaction, just in general. Yes. Yeah. You say it's becomes normal. It becomes the norm, right? So amongst youth, that it's the norm. It's the norm to start drinking from Puza Thursday all the way to Sunday night and have a hangover, possibly not go to work on Monday. It's the norm, right? Okay, what else? Mm-hmm. Exactly. Mm-hmm. Mm. Mm-hmm. Mm. Yeah. 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 Yeah, no, the industry, the corporate environment, happy hour is part of team building. It's all integrated into the work environment, the ethos of the organization, and so on. And so it becomes the norm. It becomes the norm to socialize around alcohol, and there's a very fine line between what is social drinking and what is drinking irresponsibly. So, yes. And then, of course, on the other spectrum of social drinking and using in a responsible way, we have those that really drink so recklessly that they really don't know what they're doing. They drink and drive. They are involved in road accidents. They kill people. And there's a lot of violence in the home. You're destroying families. And there's a lot of users that are actually reaching out for help. They want to be helped, but very often there's a loss of control. And despite the actual need to change, it's very difficult for them to actually start. Yeah.
Culture is even such that if you don't drink, you are perhaps ostracized.
Mm-hmm.
Those kind of areas.
Mm-hmm. Absolutely. So basically, part of the peer group mechanism is to be part of a group, to be part of a friend circle, you've got to consume large quantities of alcohol. If you don't drink as much as your friend there, then it's frowned upon, and you're a wet blanket, and you're a party pooper, and all those things. So yeah, there's a lot of pressure. So you are the closest to the community. You are the ones that know the experiences, the lived experiences of those who have been through the journey of recovery, and those who are still trying to recover, those that are still reaching out for help. And it is really important for us to strengthen these networks, to grow these networks, and to expand our support. Keith and I were talking about how we are going to try and help those people who have those tri-diagnoses, those people who are really struggling with not just a mental illness, but a chronic disease and a substance use disorder. And I know it's a tall ask for this group that's already probably stretched to try and meet the needs of those who are using substances. But how do we ignore their other problems? How do we just say, okay, we're just going to focus on this? And this is the problem that we have within our public health system and social development, where we're trying to collaborate, but very often treatment centers will not treat the psychiatric illness, and the psychiatric hospital will not treat the substance abuse problem. So what we have is ping pong therapy, where the patient is being referred from one to the other, to the other, to the other. And unfortunately, a lot of them also fall through the cracks. And we find those on the streets, homeless, wandering the streets. We find them in prisons. And we find them ostracized in their own communities. So it's really important for us to look for those, for us to reach out to them, because they are the ones that have not been able to receive the service within the public sector. Right. So what is your role? Your role is to sensitize, to raise awareness on the impact of substance use. Your role is to detect, to recognize and discover possible features of substance use disorders that need to be explored. Your role is to screen, to administer the audit and the DUDIT screening tools to individuals and identify their level of risk. Your role is also to assess risk, to identify the appropriate response and/or intervention, and to diagnose. The assessment helps clinicians to diagnose. They use the DSM-5 to diagnose the substance use disorder so that they are able to recommend a holistic treatment plan. So can you see how important the screening is and how it can lead to a knock-on effect in terms of how that person is able to access the appropriate treatment. Right. So I think on your pack there you will see a flower that I've given you today. Okay. I want you to think about your darkest moment in your life. A time of trouble, a time of turmoil, a time where you felt a deep sense of hopelessness, helplessness, and a time when there was somebody who was able to listen to you, maybe to assist you, and to comfort you, and to be there for you. And I want you to describe some feelings on the petal of how it felt to you to be able to be accepted and loved and welcomed by that person. So I want you to write down. This is very important. Right? Write down the feelings that you felt during this encounter. Okay. Anybody wanting to share what those feelings were? Hopeful, yes. Relieved. Accepted. Yes. Heard, understood, safe. Shameful. Did that person make you feel shameful? You were feeling shameful? Oh, okay, but how did that person make you feel? You were feeling shameful, but how did they make you feel shameful? Oh my goodness. Bad one. Okay. Rescued. Yes. Understood. Comforted. Safe place. Important. Good. Loved. Seen. Validated. Guided. Wonderful. Those are wonderful, wonderful feelings. And if you think about that experience that you've had and how it may have been the first step in your recovery. Okay? So this brings us to our second session. And in this session, you are going to learn how to confidently administer the audit tool, right? And you will definitely feel confident in administering this tool because this is a validated tool. It's been validated by the World Health Organization, right? It's the alcohol use disorder identification test. When we say it's been validated, it's been tried, it's been tested, and it's been proven to be an efficient tool to use for alcohol use disorders. Right. So remember the approach. Remember our flower, our feelings there? Our flower of feelings and how it felt. Now, before we screen, right, we need to prepare ourselves to be that person that made you feel secure, safe, loved, comforted, guided. That person. You need to be that person. When you start doing the screening, prepare your mind, prepare your attitude, prepare the environment that you are in, that it's in a safe place, right? That it's in a confidential place. There's privacy. That person will feel warm and welcome and accepted. And this is how you start. You start by saying, I would like to ask you some questions that I ask all my clients. Right? These questions will help us decide on the best possible care for you. As with all the information, your responses are confidential. If you feel uncomfortable, just let me know. Okay? Now, the importance of using a validated screening tool is that we do not make a person feel judged, shameful, right? They don't feel stigmatized by the things that you say, by a slip of tongue, like, okay, but you say you don't drink, but you've got pooza face. I mean, really, I've heard it said. Hey? But you're stinking of alcohol. Right? Have you heard these things before? Eh? Yeah. We've all had these experiences where we've heard some ugly things said to people who use alcohol and drugs, right? It's as though you can speak to them any old how and they must accept it. And it's not right. Okay? We treat them like we would treat any other person, any other patient coming in for help. This is how we treat them, with dignity and respect. So when we look at the audit, there are 10 questions, right? And they are broken up into 3 domains. And this is very important. I want you to really take some time to absorb this, right? You will be able to identify with the signs here. The first section, or the first domain, has 3 questions. And when you ask these first 3 questions, they are testing for hazardous alcohol use, right? Hazardous. Those people that drink frequently, they drink higher than the standard drinking limits, and of course, the quantity that they drink is more than what they should be drinking. So, first 3 questions related to frequency of drinking, typical quantity, and frequency of heavy drinking. Right, so if you look at your audit tool, if you look at your tool in your pack, right, if you look at the first 3 questions, the first question says, how often do you have a drink containing alcohol? How often do you have a drink containing alcohol? And the answers are never, monthly or less, 2 to 4 times a month, 2 to 3 times a week, 4 or more times a week. Okay? So when the person answers maybe 2 to 3 times a week, there's a score there, 3. So you would put the score down 3. Okay? You understand that? You're not going to put the number of drinks down or the number of times a week, right? You're going to put down the number in the bracket, right? So that's the first question. The second question tests for typical quantity. So it says, how many drinks containing alcohol do you have on a typical day when you are drinking? On a typical day, 0 is 1 or 2. Then it's 3 to 4 drinks, 5 or 6 drinks, 7, 8 or 9, and then 10 or more drinks. So depending on what option they've chosen, say for instance they've chosen 5 or 6, what score would you put down on the 2? Good. The third one talks about the frequency of heavy drinking. And so, how often do you have 6 or more drinks on one occasion? How often do you have 6 or more drinks on one occasion? And the options are never, less than monthly, monthly, weekly, daily, or almost daily. Right? So it says, skip question 9 and 10 if the total score for the question 2 and 3 is 0. So basically what they're saying is, you have to skip all the questions and go to question 9 and 10 if they've scored 0 in the first 2 questions. Do you get that? Right? It means that they are telling us they don't have a problem. Right? So they're going to ask the question in a slightly different way, a different angle, right? So you go to question 9 and 10, and this is how the question would be put to them, right? Have you or someone else been injured as a result of your drinking? Okay? So they need to answer no, yes, but not in the last year, yes, during the last year. Okay? And the second question you would ask them is question 10. Has a relative or friend or a doctor or another health worker been concerned about your drinking or suggested you cut down? No, yes, but not in the last year, and yes, during the last year. Okay, so basically, we know that many people who use alcohol are in denial. And they will not admit to the amount they drink or the frequency they drink and so on. So we need to ask them questions about what other people think about their drinking so that we get a better view of what maybe is going on with that person, especially if we suspect, we have a high level of suspicion, right? Yeah, pooza face, especially if there's pooza face. Okay, so do you understand that? Is that simple enough, right? So let's go to the dependent symptoms. These are the next 3 questions that you ask. And in these next 3 questions, you will be asking how often during the last year have you found that you were not able to sleep, not be able to stop drinking once you have started, right? So this shows impaired control over your drinking. So it's a lack of control. Once you start, you can't stop, right? Despite attempts to stop, you will not be able to stop, right? And you will find that many people who want to start their journey of recovery, they will also say things like, I've tried to stop, but they constantly relapse. So there'll be several relapses despite them trying to stop on several occasions. The question 5 is talking to increased importance of drinking, where drinking becomes the priority. There's lots of preoccupation with drinking. They forget about all their responsibilities, financial, family responsibilities, work responsibilities, relationships also, right? So that question, it says, how often during the last year have you failed to do what normally is expected from you because of your drinking? So they will answer never, less than monthly, monthly, weekly, daily, almost daily. So for instance, if I answered monthly, what would be the score? 2. Good. Then we go to question 6, the morning drinking. The morning drinking talks to the craving. When you have to have the hair of the dog. Isn't that so? You've got to drink the last thing you drank last night to cure the Barbie. Right. So that talks to your craving. Craving is one of the key symptoms that can be an indicator for dependence, right? As well as, of course, the impaired control and increased importance, the priorities. So how often during the last year have you needed a first drink in the morning to get yourself going after a heavy drinking session? And it says never, less than monthly, monthly, weekly, daily, or almost daily. So in this instance, if I said weekly, what would be the score? Weekly, 3. Good. Right. And then the last 4 questions talk about harmful alcohol use, right? Harmful alcohol use. So question 7 is guilt after drinking. So a number of people who have had binge drinking and so on usually have a lot of guilt the day after. So how often during the last year have you had the feeling of guilt or remorse after drinking? So never, less than monthly, monthly, weekly, daily, or almost daily, right? If I answered 3, if I answered monthly, if I answered monthly, what would that be? 2. Good. Right. And then question 8, how often during the last year have you been unable to remember what happened the night before because you had been drinking? And the responses are never, less than monthly, monthly, weekly, daily, or almost daily. Okay? And if I answered daily or almost daily, the score would be 4. Right. So we've been through question 9 and 10 as well. So we've been through all the questions in the audit, right? And what you would do then is that you would add up the scores and then you would record the scores right at the bottom there, right? Right. Now we've been talking about standard drinking limits. Are you all aware of what a standard drinking limit is? You know? Everybody? So I can skip the slide. Hey? Must I go? Okay, right. Okay. Okay, so this is the chart for standard alcohol drinks. So a glass of wine, 125 ml, is 1 standard drink. Okay? Not the goblet. It's not a standard drink. Okay? And a single measure of spirits is 25 ml. That's a tot. I know some of you think it's 30, but it's actually 25. Right? And then a bottle of cider, 330 ml, is 1 serving. A can of beer or cider, 330 ml, is 1 serving. A cartoon of, I think it's Ijuba, is also 1 serving. And then the mkompoti and the skelem kemer and the punch is 1 serving. I think if it's a 500 ml, the 1 liter is 2 servings, and the 250 is half a serving. So if you look at the bottle, a bottle of spirits, you should be able to get 30 servings out of this. So if you divide it, 25 divided by 750, you should get 30 servings out of it. Okay? Not 4. Okay. Right. And a bottle of wine, you should also get 6 servings out of it. So for instance, if 2 men are sitting down with a bottle of wine, you should comfortably have 1 bottle of wine and be within your standard drinking limit, right? Because you can drink 3 standard drinks, men, per occasion, and women, how many? Don't be like that. 2 for women and 3 for men. Okay, and then a quart of beer or cider is 2 servings. A double whiskey is definitely 2 servings, not 1. Okay, and we've been through the punch. So, okay, this is just for larger drinks. I thought I'd just give you this. A can of lager or cider, the 500 ml. Usually there's about 4% of alcohol in it. So that's 2 units or 2 standard drinks. A glass of wine, 175 ml. That's your slightly larger glass than the small wine glass. That usually has about 14% of alcohol content in it, and that's 2.5 units. And your spirit and mixer, 25 ml, usually has between 40 and 43% of alcohol in it, and that's 1 unit. And your flavored alcohol drinks, your Alco Pops, the 400 ml usually has about 5% alcohol in it, and it's 2 standard drinks. Your cocktails, this is a dangerous one, guys. Because they taste good, right? But they are lethal concoctions, right? Because this could be 5 units of alcohol in it, right? So just say a strawberry daiquiri, for instance, right? That's 2 units. Your Long Island is about 2.5 to 3, because you must look at the different types of alcohol it contains. Sometimes it contains 4 to 5 different alcoholic beverage. So the legal blood alcohol limit for driving is less than 0.05 per 100 ml of blood. The legal breath alcohol limit is less than 0.24 milligrams per 1,000 ml of breath. And of course, if you want to drink sensibly, you need to follow the guidelines. You need to know exactly what is in an alcoholic drink, right? I'm not talking about those who have an addiction. I'm talking about those people who have been drinking socially, who do not have an addiction dependency, and who are not risky and harmful users, right? If you want to be a social drinker, then you need to know the guidelines. You need to know how much to consume. You need to know that if you're a woman, you consume no more than 2 drinks per occasion, right? And not more than 4 standard drinks per week. Also, you should have 2 alcohol-free days per week. With men, you should not have more than 3 standard drinks per occasion, not more than 21 drinks per week. Also, try to have 2 to 3 alcohol-free days per week, and always drink water when you are consuming alcohol. And the other thing that you should remember is that 1 standard drink takes 1 hour for your body to metabolize it. 1 standard drink takes 1 hour. So you should sip your drinks very slowly. Okay, I'm speaking to the wrong people. Sorry. It's wrong audience. I forget. Okay, so this is a video. It's a role play, but unfortunately it's 1 hour long. So the link is at the bottom, right? I'm going to ask, we can play 5 minutes maybe. It's just for us to experience how to do the audit and the manner in which the ethos of the whole audit experience. But we'll play 5 minutes of the video, and for homework, you can go and listen to the video.
Hi, Tandu. We're going to do the audit. It's just a screening tool around alcohol use for the past 12 months. There's only 10 questions. Okay, so for question 1, how often do you have a drink containing alcohol? The options are never, monthly or less, 2 to 4 times a month, 2 to 3 times a week, or 4 or more times a week.
You can say 2 to 3 times a week.
Okay. Question 2, how many drinks containing alcohol do you have on a typical day when you are drinking? The options here are 1 to 2 drinks, 3 to 4, 5 to 6, 7 to 9, or 10 or more drinks.
5 or 6 drinks.
Okay. So for the next questions from 3 to 8, the options for your answers are either never, less than monthly, monthly, weekly, daily, or almost daily. Okay, question 3. How often do you have 6 or more drinks on one occasion?
Monthly.
Okay. How often during the last year have you found that you were not able to stop drinking once you had started?
You can say monthly.
Okay. Question 5. How often during the last year have you failed to do what is normally expected from you because of drinking?
You can say monthly.
Okay. Question 6. How often during the last year have you needed a first drink in the morning to get yourself going after a heavy drinking session?
Less than a month.
Okay. Question 7. How often during the last year have you had a feeling of guilt or remorse after drinking?
Never.
Okay. Question 8. How often during the last year have you been unable to remember what happened the night before because you had been drinking?
Less than monthly.
Okay. Question 9 and 10, your options are either no, yes, but not in the last year, or yes, during the last year. Okay, question 9. Have you or someone else been injured as a result of your drinking?
No.
Okay, last question. Question 10. Has a relative or friend or doctor or another healthcare worker been concerned about your drinking or suggested that you cut down?
Yes, during the past year.
Okay. Thank you, Tandu. I will be quickly calculating this and I will give you some feedback in a short bit.
Okay.
Thank you.
Tandu's total score was 17. In the pyramid, it falls under zone 3, which is harmful risk. The action steps for harmful risk are brief counseling and continued monitoring.
Okay, do you have an idea? Did you see how quick that is? Right? It takes between 2 to 5 minutes to basically do the welcome, the introduction, and to actually ask the questions. With the brief intervention, it can take up to 15 minutes, but it's really a very quick tool to use. It's 10 questions, but it is hitting right home, and it gives you the answers that you want, and it gives it to you in a factual way. You're asking the question in a professional way. There's no slurs or agendas or anything that will make the person feel uncomfortable. Unless they are really struggling, then they're going to be, trying to answer it or not answer the questions honestly. Okay, but the one thing I wanted to also pick on in that video is, did you note the relationship between the client and the healthcare worker administering the actual tool? Did you see that there was a very open, safe space, that she was able to make him comfortable and ask the questions in a quick and efficient way, and that there was no feeling of uncomfortable, or the person did not feel uncomfortable in that environment? Right. So the spirit of motivational interviewing must be the guide, right? And motivational interviewing is another session that we will be having, because it's a skill you need to have on how to change behaviors, how to move a person from a pre-contemplation stage to a stage of contemplation to a stage of action, and then to move them on to maintenance, knowing that there will be a relapse, but you are going to be there to start the process all over again. All right. So, is there something? No. Okay. So, if you looked at the scores and Tando's scores, they had rated Tando in zone 3, harmful risk. And if you look at the scoring, scores 1 to 7 is low risk. Okay, let's start with abstainers, is 0. Zone 1 is low risk. The action step there would be alcohol education. Educate on the safe levels of alcohol use. Discuss the consequences of alcohol misuse as risk factors for poor TB, HIV outcomes, but generally poor outcomes in terms of their lifestyles and the consequences of risky use. And then hazardous risk is zone 2. You score between 8 to 15. The action step is simple advice. You educate on safe levels of alcohol use, discuss the consequences of alcohol misuse as risk factor for poor TB, HIV outcomes, poor healthy lifestyle, motivate towards changing drinking behavior. Zone 3 is harmful risk. You score between 16 to 19. The action step then is brief counseling and continued monitoring. Educate on safe levels of alcohol use, discuss the consequences of alcohol misuse as risk factor for poor health outcomes, provide a brief motivational interview to reduce risky drinking behavior, assist in making choices that reduce alcohol and HIV risk. And in zone 4, possible dependence, you score between 20 and 40. The action step is referral to a specialist. Educate on safe levels of alcohol use, discuss the consequences of alcohol misuse as risk factor for poor health outcomes, provide brief motivational interview to reduce risky drinking behavior, assist in making choices that reduce alcohol and HIV risk, and refer to specialists for further alcohol treatment. Okay, is that simple enough? Okay? That you are able to offer some kind of intervention knowing the level of risk, that it is an appropriate, it's not like overkill, you know, it's not like, oh, this person is drinking socially, now you want to go the full hog and you want to do a full-on motivation and whatever. So you actually, it's an individual a need assessment of where that person is at, and you meet them at the place where they are at, and you intervene where they are at. Okay, so we do not have much time. I would have loved for you to practice, but I can see it's already past 8 o'clock, and we did have a deadline. I think that you have had a look at the video, and I would encourage you to form pairs and role play this in your own time. Go through the tool and familiarize yourself with the tool, and then do your own role plays, if that's okay. Okay. And maybe the next session when we come, we can do a refresher, and we can actually have people come through and show us how they have role played the audit. Would that be fair? Right? Okay, cool. Right. So, just to summarize and recap the audit. Right, it's developed by the World Health Organization. It's tested. It's adopted in several countries. including the US, including in South Africa. It's in English, Afrikaans, Xhosa, and Zulu. You identify persons who use or consume alcohol and where it's become hazardous or harmful to their health. It's administered by trained primary healthcare workers. Where it's administered, primary healthcare settings, emergency rooms, doctor surgeries, colleges, universities, community settings, such as substance use facilities, NGOs, DSD offices, and so it's really very widely applicable. Who would benefit? Any individual can benefit as it is used as a universal screening in settings mentioned above. Right? The duration is plus minus 2 minutes. Questions, 10 items, as we said. 3 questions for amount and frequency of drinking. 3 for alcohol dependence. 4 problems caused by alcohol. And the scoring is from 0 to 40. Risk of experiencing harm. And as we could see, less than 8, low level. Minor issues. 8 or more is positive test for unhealthy alcohol use. 20 or more suggests dependence and severe use. Okay, so that is audit in a nutshell. 1 hour down. Right. Do you have knowledge on SBIRT? Your attitude? Great. Do you think I've sold it to you? Have I sold it? Will you do it? Yeah, okay. And do you know how to administer it? Like I said, it's going to take some practice, right? It's going to take some practice, but it's not rocket science, really. I have so much of confidence knowing that you are going to be able to do it. Okay, readiness, ruler. Where are you? Where are you? Come. Remember, we've got more sessions to come. On the readiness ruler, how confident do you feel? On the readiness ruler. No, really? Are you ready? Okay. 10 for the audit now, not the whole SBIRT, the audit, right? Audit, right? Ready to go? Great stuff. Thank you so much. Without you, this training would not be possible. Without you, recovery would not be possible. Without you, there will be no hope for those who are suffering and reaching out for help. Thank you, thank you, thank you for your time, for your dedication, for your passion, and for giving back. Give back. It works. Thank you.
Melanie, thank you so very, very much. I think we just give it a round of applause again for Keith and for Melanie. Yeah, guys, we're deeply grateful for the help and the input and the willingness. Just to be understanding with both Keith and Melanie, they spent about 3 hours with us last week, just chatting through things and through ideas and proposals and ways forward, and then have given of themselves again this evening, and have got a couple of sessions lined up over the next couple of months just to try and really put some meaningful tools into place, which we can certainly adopt. So we deeply appreciate it, and we know that you guys had a long day and pushed in hard. So once again, thanks so much. Cool, guys. So I think that will be us for this evening. Perhaps if Kerry would like to just pray us out, that would be great and much appreciated. Please be safe.
Let's stand. Father, we just thank you so much for this time. I know that we've been encouraged to give back to the community, but I know that Keith and Melanie have given us so much tonight. boosted our confidence, just shown us how easy it is and how accessible it is to screen. And Lord, just helped us to understand addiction in a bigger picture and understand that there is more involved and that we are part of treating a bigger picture as well. And so, Lord, we just pray your blessing over them as they just continue to equip communities to step into this area and to make a difference and to be of service. And Lord, we just pray over each one of us as we travel, that you'd protect us as we go home, that we'd take what we've learned tonight and we would apply it. And Father, that we would go from strength to strength in that. Pray that you would sustain us, you would bless us as we go in Jesus' name. Amen.
Thanks again, guys. Sure.